Hi guys, good morning. You're in United States of America. Good morning, guys. And if you're in Philippines, magandang gabi or good evening. And to all my friends in United Arab Emirates and Saudi Arabia, Ramadan Kareem, guys, and also Salam Alaikum. It's me, Dr. Jenny Yusuf, physical therapist and doctor of physical therapy, creator and founder of Balance and Fall Support Group and Fishigen PT and Wellness. I'm the current vice chair of the Global Health in Aging of American Physical Therapy Academy of a Special Interest Group. So I'm a certified exercise expert in aging adult and geriatric clinical specialist. So tonight for our Thanks God It's Thursday episode. So every Thursday in a Balance and Fall Support Group, we interview different innovators, academicians, entrepreneurs, and also different physical therapists and lecturers. And we have the opportunity and we are so honored to have Dr. Dale today. So Dr. Dale Avers, did I pronounce it right, Dr. Dale?
You
Avers.
did.
Dr. Dale Avers is a physical therapist, doctor physical therapist, a Ph.D. and a fellow of the Academy of Physical Therapy Association. She had many contributions in a geriatric and even orthopedic. So she was one of two authors and edited some of the textbooks that we have and earned degrees from the University of Kentucky, Indiana University, and Rocky Mountain University. She's the current professor and director of the post-DPT program in Upstate Medical University. And she had written and edited books and journals, such as the third edition of Geriatric PT. Maybe some of you read that. And also the ninth
Actually, the fourth.
edition.
The
Oh,
fourth.
now,
Yep.
fourth edition of now the ninth edition of the Hishop and Montgomery MMT.
And that's the
So
10th
now
edition.
we have the
Yep.
fourth edition. Wow.
Yep.
So she's also the associate past editor of the Journal of Geriatric Physical Therapy, and of course, previous physical therapy is also the president of the Academy of Physical Therapy Association. Previously, a section of geriatric therapy, but now it's an academy. She has more than 40 years of physical therapy experience, and now she's in academician. So that's really, really wonderful here. So we're not done with that. Let's talk about her awards and honors, guys. These are really motivational inspiration. If you didn't attend the CSM last year, the APTA CSM 2020, Dr. Dale is the lecturer of the Carol Lewis Lecture Award. So she discussed a wonderful lecture there. We'll discuss more about that. And she was awarded as the APTA Catherine Worthingham Fellowship, Lucy Blair's Award, and Distinguished Educator Award from the State University of New York. She received the Chancellor's Award for Excellence in Teaching. I hope I pronounced it right. So, Dr. Dale, thank you so much for this opportunity and welcome for our Balance and Pulse Support Group.
Thank you. It's so much my honor, Dr. Jenny.
Oh, that's really amazing. I'm checking more of your and we're really inspired just right now.
I've
You
just
know?
lived a long time. That's all.
Okay, we need to live a long time with better value, right?
That's exactly right.
Yeah, and that's my next question, Dr. Dale. I read some of your articles and you're really sending different wonderful articles and links that will help us improve about geriatrics and orthopedic. Just recently, I shared your wonderful article about hip fracture, the new CPG guidelines about hip fracture, and it has a wonderful um, outcome because all of them were able to read the article, things like that. So why do you think these things are very important for you to bring us value?
Well, let me just mention quickly for everyone that's listening in that that CPG that's brand new is going to be discussed by the authors that developed it on an international forum, because it was an international team, at the end of April. And so I'll give you that link. Jenny, it's free. And it will be in the evening. I think it's the last week in April. So many people might be interested in that, to actually hear from the authors about how it was developed and what impact it should have on physical therapy.
Yes, yes, that's wonderful. Yes, I saw that it's a free webinar series. All the authors are there when you click
Yep.
the link. So that will be, I'm sure is it only in USA, Dr. Dale, or it can be accessed?
It'll be accessed everywhere, right? Because it's
Oh,
an international team that has done it. So yeah, the link is available to anyone. And it's out of the uh, uh, Fragility Fracture Network, which is an
yes.
international network. And we give workshops every so often, and are working on a really wonderful one for balance in the fall, which
That's
I
good.
think a lot of international therapists would be interested in, because it has an international team: Australia, Canada, Sweden, and England.
Oh,
So,
we're looking forward for that. Yeah,
right,
because
right.
I have one of my colleague, which is a doctor of physical therapy and also an orthopedic doctor in Philippines. He's unable to access that link, but
Mm,
there are different articles there.
right.
That's why I want to know if do we need to be a member of the orthopedic, but there are some
No,
articles that can be open.
yep. No, it is free to everyone.
Wonderful. Thank you so much.
Sure.
All right. And next question, Dr. Dale. So that's wonderful. You said that you have almost like 40 years of experience. Can you share us how's your transition from being a physical therapist clinician to an
Mm.
academician?
Yeah, it was a little bit accidental, Dr. Jenny. I actually wasn't a very strong academic student. I had a lot of passion for the clinical side of physical therapy, but I just, maybe like many people will understand, I just couldn't wait to get out of school. Um, it was a little abstract. And so the idea of me being in an academic environment is always a little ironic to me. But I enjoyed clinical teaching tremendously. I really value clinical reasoning and figuring out why we do the things that we do, why patients respond the way they do or don't respond. And so several people took notice and encouraged me to go back to school. I got my master's in clinical and college teaching, and that was tremendous. And then eventually they felt like I should have more influence on my profession rather than one student at a time. And so I took a big gulp. And after 20 some years, I enrolled in a PhD program and actually went full time, which is unusual to be able to take that kind of time off in the middle of one's career. I was actually serving as president of the then section, now Academy of Geriatric Physical Therapy, and was able to really devote myself fully to both of those jobs of being a student and also the president. And it changed my life. It changed the way I thought about things. I became more of a global thinker rather than, we have to deal with individual problems so often as clinicians, don't we? And sometimes it's hard to take a step backwards. And that's what I was able to do. And I think it really changed how I looked at physical therapy, my patients, really in the world. So it was
That's
great.
really good.
Yeah.
That's really
Yeah.
good. That's amazing. I'm
Yeah.
just reading some of your profiles and also some of your articles. That's real good. I watched your video about your lecture and the Carl Lewis lecture. Can you
It's a
share us
little
more?
long. I'm proud of you, Jenny. I was told it had to be 90 minutes. Oh my goodness.
It is. It is like I think like 1 and 45 minutes, something like that. And that's really good for the Fox to record that for the others who are
Yes,
able
yes.
to. I believe they sponsored it, so that's wonderful. And also, it is a wonderful topic. We talk about ageism, the value of a physical therapy, and the importance of evidence-based research. You even discuss what are the exemplars and standards. So tell us something, a little bit of bullets or nuggets that we can take
Yeah.
from the lecture.
Yeah, as I get close to retiring, I do a lot of reflection on physical therapy in general. And I think becoming complacent is really our enemy, that we must always strive to do better. And that was really the theme of my distinguished lecture, is that as much value as we have, there sometimes it's not so apparent because of individual therapists and the way we treat things. And so we must always want to do better. And that means that we have to continually ask ourselves, why are we doing this? How do we know that this works? Are we open to recognizing that maybe it really doesn't work for as many people as we thought? So the take homes from the lecture, as far as my perspective, is that one, we can't do this in isolation, that we have to be most effective as a profession, we must work with other groups. And that means that we need to be patient-centered and look at really the like the WHO, the World Health Organization, as an example, to plug into them so that we can sell ourselves and be team members. So I think geriatrics is such a complex entity, and we need each other. I think two, one of the take homes was about intentional aging. So we all know people who don't like to think about their own aging, and so they ignore it. And then many, many years later, they're frail and they don't know how they got there. And if they had just gone back and in your 50s and 60s, think about how you want to be at the end of your life and do something about that, then that's intentional aging. And I feel physical therapy is an ideal partner for that kind of thought process, that we need to ask people, what is their vision for the last third of their life? And we're all living longer now. And so we have a responsibility to live that as best we can. And certainly we all know that physical activity is one of the best things that we can do. So as physical therapists, are we building on a foundation of physical activity? You know, we have lots of sophisticated techniques, but we have to go back to that physical activity. How active are people? I think in my world, we always complain about how many people, especially in long-term care, the recidivism, right? We treat people, we get them to one point, and then we discharge them, and then a few months later, they come back. And it's that big cycle. Well, why do they come back? Because they're not doing anything on their own. We haven't empowered them or made the environment such that they can be more independent from a physical activity perspective. And so we have to do that. And I think that's a real untapped potential in our profession. And then I think the third thing was really the exemplars, kind of establishing what is excellence in physical therapy. And then I did some suggestions for what that actually means and how to get there. So that's kind of encapsulated an hour and a half of
That's
in
true.
5 minutes. Yeah.
That's really true. And then that's really good because you discussed there the importance of the high intensity training exercise nowadays. But you discuss also that we need to do more, not only the rational, like we call it decajon, hat pack, tense machine, and then ultrasound. We only use TheraBand. We degrade them, but they can have a potential of using those weights, you know. And
Of
and
course.
then I just interviewed Dr. Joni Barry, and then
Mm.
I told her, congratulations, Joni, you're doing great. And then she explained to me the difference of power building and body weight and things like that. And
That's right.
aging and older adults are really good for that.
Yeah, I
What
think
can you
sometimes,
add on?
Jenny, yeah, I think sometimes therapists are afraid. They're afraid of the fragility of some of our patients, literally that they might break if we load them too much. I've taught all over the world, and I address that, and I don't want anyone to feel badly about having that fear. But I think, again, you have to push into that fear. You have to think, really, is really the femur going to break if I have them on a leg press and push their body weight? And of course it's not. I don't know that that has ever happened because they're in really good alignment. And certainly we know fragility fractures happen, but they happen kind of on their own, right? As simple as just bending over. There doesn't seem, it's just kind of the straw that broke the camel's back, so to speak. So I think we have to look at appropriate dose. And there is a preponderance of evidence that shows that more intensity gets better results faster. And frankly, our patients don't have a lot of energy and time to waste in our exercise program. So we need to convince them that this is going to be the best way. And that's just something we have to keep working at.
That's really important. I always emphasize and explain to my clients that body weights, putting your weight is very important, increasing bone density, preventing your osteoporosis and osteopenia, something. So when they explain the importance and also about better posture to prevent rib compression fracture.
Which
I
takes
like,
strength in your trunk,
yes,
right?
the
I mean, you
core.
have to work that too. Yeah. Yep.
Yeah,
Yep.
those deadlifts improve the core. I really learned from different interview I'm doing. We have many different manual therapists and explain the value of those, like Dr. Erson Relioso as well. So they are very good manual therapists, Dr. Dale.
Yeah,
So
there's a fact that I is so compelling to me. Bortz talked about this way back, and he said it takes only 15% of one's baseline strength, like what you had when you were younger, say at the age of 30, to maintain upright stance and walk unassisted.
wow.
That's 15% of your back strength. That's all it takes. And look at how many people cannot do that, that they're leaning on a walker, they're leaning on a cane. They can't stand upright, which means they have lost more than 85% of their baseline strength. And it's because we sit, we lean back all the time, we don't use our back muscles. So I think that's a compelling thing that's stuck in my head, and I'm always strengthening my spine. I'm always doing, and I'm just amazed, even when I go for a long walk and I haven't walked in a while, how tired my back is. That's weakness. That's all it is. And I think a lot of back pain is related to weakness.
Wow, good point. Yes. So what exercises is that you can share to our listeners for our aging and older adults? What simple exercises basic that you can teach us, and also advice for our physical therapists listening to teach their clients,
Yeah,
Dr.
sure. Well, I think you made a great point that you have to practice what you preach, right? I've
Yes.
always said that no therapist teaches a patient an exercise they cannot do. So if they're weak already, the therapist, they're
Yes.
only going to teach really weak kinds of exercises. So one of the points I made in my lecture is that we have an obligation to stay strong and to look vibrant, right?
Yes.
You know, I'm almost 70 years old now, and I
Wow.
believe me, I really practice what I preach. So exercises, you know, I think certainly starting with bridges and making sure people do them well, like get up as high as they can and squeeze their glutes
Okay.
together at the end so that they do them with intention. Again, up and then lowering slowly. So 1 to 3 seconds, you know, the ratio of up 1 second, down 3, so that you're working on those eccentrics. So that's all just exercise science, right? And then going to one leg. So that's really very important. And then using your arms straight up overhead while you're doing bridges so that people aren't inadvertently pushing down with their arms. And then putting feet up over a ball and then doing bridges. There's lots of progression with bridges, and it's one of the best. In fact, I read an article, and this is fun, just standing and turning your feet into external rotation and squeezing your butt muscles together as hard as you can isometrically actually has a very good voluntary contraction.
Wow.
Very high. So I try to do that when I'm just standing around, right? Standing in a line is just squeezing. But I think doing like prone, you know, the arm, like a bird dog, we call it in the US, one arm up and the opposite leg back, strengthening that spine, laying on your stomach and just doing back arches, even press ups will help for those people that need their arm support initially. Those are all really good exercises. And of course, planks. So I have to talk about my 90-year-old mother, and she can hold a plank for 2 minutes. She
Wow.
goes, this is easy, right? She's amazing. And I get to see her for the first time Mother's Day after a year, and she has surprises for me, and that's about her physical activity. So she just keeps working, and she has beautiful posture. So it can be done. I just think we need to have those high expectations for our patients. And I really do think that an awful lot of back pain that older adults complain about is about weakness. They don't have the support of the muscles because they don't use them.
That's true. The core exercises, when you say 1 second up and then 3 seconds down, so I'm thinking like, yeah, because I put it like 5 seconds hold, but so I need to improve the eccentric part,
Right.
because I keep
The
telling them
eccentric.
do it
Yep.
slowly, but I don't have the count
That's
as
right.
well. I think I need to
Exactly.
improve the count.
Yep.
So and then sometimes I begin first with 5 seconds and do as more as you can. But I think I need to improve more on like the one leg
Exactly.
leg raise and those things, and the
Yeah.
upper.
Yeah.
So
Remember,
what
we got to work within that intensity of 60 to 80% of a 1 RM. That often equates to anywhere from an 8 to a 12 repetition where you
yes,
can't do any more. You know, we
that's their
often just
1
give
RM.
people 10 repetitions, but what if they can do 30 or 40? Then they're working at a 20 or 30% RM, and that's not helping them. So I tell my students, you never ever tell someone how many to do. When they ask you, how many am I supposed to do? You go, let's see how many you can do. And if it's too easy, they're just doing them really quickly, then we have to make it harder, like single leg bridges.
Yes.
Yeah.
So just do, and then we can always ask them like your tolerance, and when you feel tired, that means that you are 1 RM, and then repetition, improve the frequency, you
Right.
know.
Yeah.
So when you're doing lots of frequency, and then I explain the endurance and what is strengthening.
Yeah.
So that's very important. What is their goal, as what you've said, Dr. Dale? And then when they see that this is for their specific function, I want to carry my granddaughter. Okay, so that's more in strengthening.
Yep.
I want to do things like this faster. Okay, so we'll work on
Power.
like what, endurance or
And power. Yeah.
power. Okay.
Yeah.
So
Yeah.
so at least that's what we will focus on. So those are wonderful tips, Dr. Dale. So how about your challenges in your career as an academician and also as a clinician?
Oh, I think all of us have unique challenges, don't we? So I think mine was kind of being, I felt like a lone voice for a long time, especially about strengthening. You know, you keep having the same message and people are like, wow. And you feel like you've been talking about it for 20 years or even now, you know, this is something I've built my career on, is appropriate dosing, and still people are not doing it. I get very frustrated with that, frankly. I don't understand why they might think so little of older adults that they are not giving appropriate dosing. And I feel badly for this. In fact, I'm reviewing a very big chart right now on someone, and I feel so sorry for this gentleman. He's not gotten any better over the years. I'm tracking his functional measures, and it's because the dosing and the kinds of exercises are just not specific or intense enough for him to gain strength. And he's been doomed now to being disabled because his therapist is not doing the right thing. And that's what we have to look at. That is one of my biggest challenges, is how to help therapists recognize what they need to be doing for these valuable people in our lives that need us. And frankly, if we don't do it, no one else is going to. We're the physical activity people. We're the movement people. No one else is going to do that. And so if we don't do it well, I don't think it's going to get done. And that means older folks may become dependent when they don't need to be. And that is so sad. That is probably my biggest challenge.
Yes, that's straight to the point. So that's true. You can really, it hurts our heart, especially if we ourselves, we don't really do it better on our clients. And then we really need to strive harder. And that's the lecture that we discuss. We can do better,
We
you
can do
know?
better.
and that's the value. So that's how you expect us to do. And you're always telling us these are the ideal, improve this, you can improve yourself. And you also discussed, Dr. Dale, that if you are a doctor of physical therapy, you've noticed that this new entry level doctor and other doctors are not really using their doctorate level. Like
Right.
they're a little bit shy to say that they are doctors. Why do you think you find it in your students? And what's your input with that?
Yeah, I think that's a really big issue, is whether or not we are living up to our credentials. So I'm proud to be a doctor of physical therapy. I have my doctorate in physical therapy as well through a transitional program. And I introduce my patients as, hi, I'm Dr. Avers. You may call me Dale. It's as simple as that, but I set it forth that I am a doctor of physical therapy, and patients really respect that. If you're all dressed in casual wear, right? And you just say, hi, I'm Dale, I'm going to work with you. They're looking at you like, huh? You haven't established that professionalism. And so I think it may feel really formal at first, but it's an important first impression. And I think we need to take that more seriously. Why it doesn't happen more? Physical therapists typically are very nice people, aren't we? We don't like to rock the boat very much. It's our personalities. And I think sometimes maybe our colleagues that have 15, 20 years more experience than we do, that don't have their doctorate, it feels a little uncomfortable to maybe only have a few years of experience and call yourself doctor, but you earned it. It has nothing to do with that other person. It has to do with your relationship with the patient. And if somebody looks at you and raises their eyebrow, you just need to be tough. You don't have to lord it over anyone, but you need to establish that relationship with the patient. And I don't feel like we do that well enough. And I don't feel like we sell ourselves well enough.
Really a great point, Dr. Dale. It's really a nice, very well said, because that's really the challenge of even new therapists right now. We want to improve ourselves. And then that's the reason why you studied hard to earn that doctorate. But until now, they're not really comfortable saying that I'm doctor. And some controversies in their work, that some of the MDs are confused. So many, we educate them. I exactly say what you're saying. I'm Dr. Jenny. You can call me Jen, and I am your physical therapist. That's it. Just the clarity is there. But
There
you
it is.
made an impact from day one that this is my physical therapist. I will be good. They will take care of me, something like that.
Yep.
And that's the best thing that we can serve for them. We're giving value. Now he will listen. This is not a typical thing that just passing. I need to listen because I'm paying. They have the idea. That's
Yep.
really good. Yes, thank you so much, Dr. Dale, and that's really wonderful tips as well. So, what will be your um tips for us, like your important books and courses that you can recommend so we can improve more?
Well, I always have to recommend the CEEA course of the Academy. That was built on the years of exercise and functional assessment lecturing. And now they've developed 3 whole weekends and an advanced course even. And so it's gone far beyond what I initially gave the Academy, but I'm so proud of it because I think it's really needed. And it's a wonderful network of colleagues where you can kind of really talk about the challenges of appropriate dosing and get great ideas. And it really forms a community, because I think sometimes when, we know that treating older adults is typically half of most therapists' load, right? But how many people actually specialize in geriatrics? And so those specialists have to communicate best practices to everyone. And and it's taken us some process to get there. And now we're dealing with somebody who likes to just do manual therapy on 40-something-year-olds, and they don't really appreciate the nuances of a 70-year-old. And you're telling them you got to load it, and they're going, what? And so I think the CEEA course provides a community that you can talk about those problems and develop solutions that will help communicate best practices to everyone. And I really, really like the ICE program. Dustin Jones and Christina Previtt are just doing a fantastic job of communicating appropriate dosing. They're young, they're fun, they're innovative, and I highly recommend that course as well. I think it's just great. And then there's, more to maybe the audience's interests. I think there's balance kind of things that, there's an awful lot. And I talk about this in my lecture. The best practices for balance really need to be communicated well. I am a big proponent of perturbation and teaching balance recovery rather than talking about falls. So as I mentioned in my remarks to you, I think there's a really good article that just came out in our journal, isn't there, about older adults' perception of physical therapists and regarding fall risk. And I think we have to admit that anyone over 65 has fall risk, right? We don't even need to test that fall risk. Everyone has it. And it just depends on what kind of challenges that person undertakes. And so rather than talk about fall risk and mitigating that, we need to teach balance reactions so that people can recover their balance under a variety of different circumstances. And I've seen the joy in people's faces when I let them, they've lost their balance, and I let them go several steps before they recover, and they glare at me like, why did you let me do that? And then they get the biggest smile on their face. I caught myself. Exactly, right? Rather than me catching them, and all that teaches them is they've got to be dependent on me. They can't take challenges unless I'm going to be there. And that is so awful. So the newest literature is talking about the importance and the rapid improvement in balance recovery with perturbations.
Yes.
And I just love that, teaching the crossover step. So we know that older adults that can't get their leg quickly enough over the other leg to catch their balance are more likely to fall to the side. And so we teach that. That's an important thing to do. And that means we have to challenge them so that they will lose their balance instead of constantly keeping them safe and not letting them lose their balance. That's really, really important. Now, I'm not aware of a course that's teaching that in of itself, but I think it's something we really need to get a handle on and feel comfortable with.
When you speak that, Dr. Dale, I have Dr. J.J. Maudertini who discussed that. And
he's another New Yorker. Yep.
Yes. And they have the Neuro Collaborative Training or group. And then she also was our speaker last time when we did one of our summit. And that's what exactly she discussed, Doctor. The perturbation and also the retroactive. And I totally agree. They even don't have an age. You are always a fall risk.
That's right.
Exactly.
That's right.
Any age, you're fall risk.
That's right.
They said, so we just say high, moderate, minimal, risk, but you are at risk.
That's right.
So
exactly.
That's true. So and I agree with Dustin and Christina Previtt. They have the management, MMOA, the management of older aging adults.
Yep. And that's now under ICE.
And Cherry on ICE.
Yeah, and that's a really good resource so that anyone can sign up for that, and you get a weekly digest, and it always has something about older adults and a good article.
Every Wednesday they will have, if you subscribe to Cherry on ICE and then ICE Hump, because it's a Wednesday email, and every week they have those kinds of nuggets for that.
Yeah, I think it's excellent. Yeah.
Dustin is really good, and he is also geriatric clinical specialist. Shout out to him. And he, as what you've said, Dr. Dale, he emphasized that it's not more on prevention. It's more on preparedness.
That's right.
So we are really
That's
kudos
the
for
theme
this
of the
wonderful.
future. That is the theme of the future. Yep.
Yes, and that's what they're focused more.
Yep.
The hit, the dosing,
Yep.
the different intensity exercises there.
That's right.
And
That's
Christina
right.
is from Canada,
Yes.
and they
Yes.
joined each other. Yes, so I know them,
Yeah.
and we'll check on more about their programs. So thank
Yeah.
you so much, Dr. Dale. This is really wonderful. I know that you have lots of things to do, but lots of things that you share to us are very, very important. And all our listeners, physical therapists and clinicians, and also our aging and older adults, learn a lot from all the things that you've shared to us. You're wonderful, and we are applaud to you. So, any closing remarks about your tips, why you move, and why important? What's the importance for that?
I actually moved to make sure that I am always functional. Being an expert in aging, I want to exemplify what aging can be. And so that is probably one of my greatest motivators, but I exercise nearly every day. I never miss more than 2 days a week. So I think that's really, really important. But I'll just encourage everyone to just strive to be as good as you can be. Strive for your own personal excellence, and your patients will so appreciate that.
That's really nice. Do what we preach. I like that. And then also, we can do better. That's what I keep thinking. We can do better. We
Yeah.
can serve better.
We always can do better.
Yes, that's the reason why we have this evidence-based research. We have these functional outcome measures. Improve yourself, and the outcome for your clients will be better. And that's the reason why other clinicians are studying more. So some people are asking why you keep attending seminars, courses, because that's for you. Invest in yourself, right, Dr. Dale?
That's
So that's
exactly.
it. Wonderful tidbits
Thank
again,
you.
guys. I hope you learned a lot from our Thanks God It's Thursday episode with Dr. Dale Avers. And it's really an opportunity for all of us, guys. She is a treasure. So thank you so much, Dr. Dale, for all your contribution. And she's not only geriatrics, that's why she emphasized everything, because she's also had wonderful experience in orthopedics. So if you have any questions, you can connect with Dr. Dale. Dr. Dale, what's the best way for us to connect with you?
Probably email is the best. I'm also on Facebook, so feel free to friend me. But if you just contact me through my work address, which is aversd@upstate.edu, I'm sure Miss Jenny can connect and make sure
Yes,
you have that address.
sure. And I will put it on our post once we share this wonderful messages and video. Thank you so much again,
All
Dr.
right.
Dale. And thank you
Thank
so
you.
much, guys, for listening. It's me again, Dr. Jenny Yusuf, physical therapist and Dr. Physical Therapy, creator and founder of Balance and Fall Support Group. If you have any questions, connect with us. Share with us your goals. What's your challenges? Join us and also share your different articles. And we can learn more from each other. Have a great day, guys, and God bless.